and procedures. Right? First, patient selection. What types of patients are we going to do this with? I'll give you an example of this. I was working with a neurologist. We said, well, what types of patients do you want to do this with? It's not necessarily all neurology, right? So she selected particular conditions where she felt comfortable doing teleneurology with. So I think it was like ADHD and there was a seizure thing. But she was okay with children. So patient selection that's an important one. And you kind of set that agreement ahead of time between your hub and spoke. Referral process, how does it actually happen? The new patient packet. So because this is a little bit different, you've got a new patient, what do they need to understand? And related to that, the consent form. So you have a telemedicine consent. Right? Included in that might be, what should you expect as a patient when you're going to do a telemedicine encounter? Appointment scheduling, cancellations, and no-shows. Now I can tell you, here's some interesting news. With our telepsychiatry project, between the primary care and the psychiatrist, they've been doing that project for a year and a half. Started out, really slow, but they now see somewhere around 5 to 8 patients a week in the primary care office. 0 no-shows. Pretty powerful, right? Physical surrounding and staffing. Who needs to be there? What does the room need to be set up like? Around who needs to be there, what kind of presenter does the specialist require? So do they need, can it be a staff person who presents a patient? Or do they need an LPN? Or do they need an RN? Or do they need a nurse practitioner? Some of your specialists will deal with that. Security and emergency protocols. What happens if something goes really bad? This is particularly important around telepsychiatry. Check in and check out for patients, administration billing, provider communications. These are all things that you want to have. The good news is, and I'll talk about this later, we're going to help this region get at that, and I'll tell you how we'll do that in a little bit. So all the resources that I'm talking about today, you're going to receive. Project funding. Now, the equipment that we received was from HEAL 10 grants. I think it was HEAL 10, okay? But you try to look at what's out there now. The Rural Health Grant, a USDA one, this grant is out there all the time, every year. So worth pursuing, especially for rural health areas. Notice that minimum 15% match, though. That's in there. That one's there. And then I wanted to, of course, talk a little bit about DISRIP, because we can't avoid talking about DISRIP wherever we go. Here's a couple of projects that the NCI, or the North Country Initiative, and Adirondack Health share, where there's opportunity for telemedicine. This one, in particular, the care transitions model, that's a great opportunity for health buddies or for remote patient monitoring. That's a really good opportunity, and we're down the road a ways, so you probably already have implementation plans and how you're going to achieve that. But there's a role there for remote patient monitoring. And then this one is probably one of the bigger ones, that integration with primary care and behavioral health. I don't know, from everything that I've encountered, everything that I've seen, I don't know from a patient-centered medical home arena if telemedicine will actually work, or if they will approve that. But it's certainly a delivery method that could work. So you have to tell me more about that, I think. The impact model, though, that would be one that's pretty easy. So impact model, it's a part of the district. That's one certainly that telemedicine can play a role in. If you have a psychiatrist that needs to be there, needs to respond, how do you make that happen? Do it through telemedicine. The other thing I wanted to just quickly mention is there is this sense of reimbursement. We know that that's down the road. There's certainly, you have to look at return on investment. You have to look at that. But I want you to consider, in addition to that, the value proposition. So telehealth as a tool provides more value than just numbers. So certainly improved access. If you've got to wait 3 months to see a psychiatrist or whatever it is, using telemedicine, telepsychiatry to bring a psychiatrist into your facility, that will improve access. Evidence-based practices. For example, the impact model is one. That's where you'd say, here's an evidence-based practice. How can we implement that? Using telepsychiatry. Provide decision support. Now this I'm thinking in particular, one of the projects that we've worked with or kind of been in talks with is the University of Rochester Medical Center's Project ECHO. I think they probably have been out here, right? They've been out here talking to you guys, Project ECHO. Their project deals with geriatric mental health, and that one, it's that decision support, really. I mean, it's definitely raising the level of our primary care physicians in particular. But if you've got a case and you need some support around decisions you make, that's a great opportunity. Reduce costs. Here, reduce costs, typically I'm thinking in this area about facility cost. So if you don't have to build a wing, you can work out of a closet, that's reduced cost. Improve attendance and adherence. This is a part of what I was talking about earlier with having no-shows. There's an opportunity there. Redeploying the primary care provider's time. And then I wanted to come to this one, the travel strain. So as an example of this, my dad was diagnosed with lymphoma probably 9 months ago. So we were seeing a provider in Syracuse when we first got the news, and then we said, we'd really like to get a second opinion. So I take off from work, we travel to Boston, we go to Boston, we stay the night in Boston, we travel back, and the entire time I spent in the doctor's office with my dad was probably 45 minutes. So that's a big chunk of time, big chunk of travel. We ate well, but so next steps. Here's a part of what I wanted to just share with you. Talk about acronyms: FDR, HPO, NCHP, AHI. We have this great opportunity to collaborate together. And if you haven't heard already, we're working to bring someone in my role to this area. So Adirondack Health will actually have their own telemedicine project coordinator, and it's a great opportunity to really find all these resources that we're talking about. So if you're working in different facilities, working with that telemedicine project coordinator to just give you the help that you need to guide you through the process, will be there shortly. So we hope very soon. So with that, thank you very much for being attentive and listening to me today, and appreciate your time, and we'll move on. Thank you.
David, thank you very much.